I just want to say a happy good afternoon to everyone and welcome to today's webinar. And our topic is on multidisciplinary approach to facilitate early recovery from hip fracture patients. So I just want to introduce myself. I'm Jenny Fain. I'm an assistant professor at Western University here in London, Ontario, and I specialize in orthogeriatric care. And today we have three great speakers, both from Canada and internationally, speaking on topics across the spectrum of hip fracture care, sharing their expertise on best practice and also how to develop effective hip fracture programs. But before we get right into the webinar, I just want to introduce Lauren Beaupre. Lauren is a professor in physical therapy at the University of Alberta in Edmonton, in Canada. And Lauren is also the chair of the scientific committee of the Fragility Fracture Network, as well as the co-chair of Bone and Joint Canada, who have partnered to facilitate today's webinar. So I'd just like to hand over to Lauren to give an introduction and overview of the Fragility Fracture Network.
Thanks very much, Jenny. Alina, do you want to share my slides, please? And welcome, everybody. I was going to say good morning as Jenny's saying good afternoon. So wherever you are in the world, good morning, good afternoon, good evening. Next slide, please, Alina. So as Jenny said, I wear multiple hats here, but today I just want to spend some time and really introduce you to the Fragility Fracture Network, which has a relatively low number of North American membership. And so we're hoping to sort of promote the Fragility Fracture Network and make people aware of what we're doing. So the Fragility Fracture Network, or FFN, was founded in 2011, and it really came together out of the UK, where there was recognition there were some gaps in current organizations. And so the vision of the Fragility Fracture Network is a world where anyone who sustains a fragility fracture achieves optimal recovery of that fracture, but also no further fractures. And so this was the gap that they felt needed to be filled, is that we had organizations that were really working on acute management of fractures or recovery of fractures. And then there were groups working on secondary prevention, but sometimes these were not linked, and that's where patients can fall through the cracks. The other part was really recognizing that we hear about the tsunami or epidemic of the aging population and the potential accompanying fragility fracture increase as well. And although we recognize this problem in our developed nations, the problem is actually looking a bit worse in developing nations where they have a more rapidly aging population and even more constrained healthcare resources. And so the mission is to optimize globally that multidisciplinary management, the recognition that it takes many disciplines, health disciplines, to affect really good recovery from a fracture and then prevent the next one. Next slide, please, Lina. So the FFN has sort of 4 pillars of what they call their call to action, which was published in Injury in 2018. The first is focused around multidisciplinary acute care, and that's what today's webinar is really going to focus on. The second one is on rehabilitation, which of course starts in acute care, but carries on throughout the continuum, hopefully back out into the community where patients were pre-fracture. Again, that third arm about bringing secondary prevention into the same house as these other 2 pillars. And the fourth one is also a very interesting arm that the FFN recognizes as being really necessary if you're going to affect change. And that is creating multidisciplinary national alliances. And this is to try and promote this call to action into actual action. Because although you must have a committed group of clinicians who want to change practice, you also have to be able to engage with decision makers, administrators, and policy, the purse string holders, to be able to put these changes into practice and get the support with healthcare resources. And so the FFN does this through a regionalization strategy where they work within countries and try to get the national FFNs going. In Canada, for those of us who live in Canada, we know people think about us as having a national healthcare system, but in fact we don't. We have provincial and territorial healthcare systems, each which make their own health policy decisions. And so rather than creating FFN Canada, we've decided through Bone and Joint Canada to really be a sister organization with the Fragility Fracture Network and really be able to push the information of the Fragility Fracture Network through the very effective network of an established network of MSK researchers, clinicians, policymakers that Bone and Joint Canada has already established. So we will not create FFN Canada, but Bone Joint Canada will partner with FFN to be able to push the materials that we have out through Canada as well. Next slide, Lena. So what would you get if you, for part of the FFN, why would you want to join this one? Is the FFN likes to create resources that are free of charge, free for download. And so I'm just going to highlight 3 that we developed in 2020. The first is this clinical toolkit, which is how to set up an orthogeriatric service or fracture liaison service, and across the 3 pillars. This is very much a meet you where you are document. So if you've already got some standardization in process, how would you advance it or enhance it and expand it? But if you've got nothing in place, here's how you would start. And so it can be quite small project-based things or larger pieces. And again, available free of charge on the FFN website. Accompanying this clinical toolkit, we also have a health policy toolkit, about how do you engage with policy? What do you need to do to actually affect change? And the final resource I'll draw attention to is we have also published an orthogeriatrics textbook, which talks about sort of the multidisciplinary management of people who experience a fragility fracture. And this includes orthopedic surgery, geriatrics, but also looking at the other disciplines that are highly engaged in affecting good recovery, including the rehabilitation, dietitians, nursing, as well as using performance metrics and data to actually be able to measure the impact of your changes. Next slide, please, Lena. So if you join the FFN, next slide, Lena. So membership is free, so that's easy. So please do go to the website and join, and you'll get the access to the materials I've just described. But as well, you'll also get access to a community of practice, an international community of practice. So we have special interest groups, and we have special interest groups in acute perioperative care, vertebral fragility fracture management, hip fracture fragility management, physiotherapy, and hip fracture audit, as well as secondary prevention. And so you can really meet with these international groups that are working on things. And although we talk about differences across the healthcare systems, in fact, what we see is our problems are global, and we often hear very similar things happening across the region, and other countries may be doing things that actually are very applicable in your area. So again, I encourage you to go to the website and consider joining. And final slide, please, Lena. And I'd also like to promote our 9th and Global Congress. This was supposed to be held in Toronto in September 2020, before the world changed. And this was going to be the first time that the FFN actually held their Global Congress outside of Europe. And so we were very excited to bring it to Toronto until the world changed. So we postponed it for a year. We were very hopeful that we would be in Toronto this fall. But again, with international travel restrictions, we've decided to make this an entirely virtual Congress. So we'll be doing talks that cover the 4 pillars, and we have excellent international faculty who will be talking about really topical issues in each of the 4 main pillar areas. We also have symposia with other international organizations, including the International Consortium of Orthopedic Nurses, CCOT, the COA, the Canadian Orthopedic Association, as well as the American Association, the American and Canadian Physical Therapy Associations, as well as geriatrics. And then ASBMR and IOF. So I encourage you again to consider coming to the Congress and enjoying it as a virtual event. It will be held, this is our one concession to being held in Toronto, is it will be held in actual Eastern Daylight Time next September. So I hope that Canadians will consider coming to what we hope will be a very exciting virtual Congress. And with that, I'm going to stop talking and pass this back to Jenny to talk about today's webinar on acute care. Thanks so much.
Thanks a lot, Lauren, and thank you for sharing so many of those resources. I will definitely be checking out the clinical toolkit for my own hospital here. So to get us started today, I would like to introduce our first speaker, who is Dr. Annette Hyland-Ranoff, and she will be talking about the effectiveness of orthogeriatric programs. So Dr. Ranoff is a professor of geriatric medicine at the University of Bergen and consultant in geriatrics, working as an orthogeriatrician at Diakonhjemmet Hospital, I hope I pronounced that correctly, in Oslo in Norway. Dr. Ranoff's research interests are in cognition, nutrition, polypharmacy, hip fractures, and exercise. So welcome, Dr. Ranoff.
And Lena, if you want to play her presentation now, that would be great.
Hello, colleagues and friends in Canada. I am Annette Ranhoff, a professor of geriatric medicine in Norway at the University of Bergen, and I'm also working as a geriatrician at Diakonhjemmet Hospital in Oslo. My topic today is effectiveness of autogeriatric programs. I have no real disclosures, but I am a board member and one of the founders of FFN Norway. I'm also an board member of the FFN, where I'm a representative of the European Geriatric Medicine Society. The background for this is that both Canada and Norway have a high 10-year probability for getting a major fragility fracture, as you see in the right graph. If you look at the left graph, you will see the incidence of major fragility fractures, where Norway is on the top together with the other Scandinavian countries and Austria, and Canada is on the middle part in the world. But in both the countries, this is a great challenge. This is my hospital, Diakonhjemmet in Oslo, which is a local general hospital where we from 2004 have organized autogeriatric care. And I've been involved in this from 2005, and it has been a great experience, and although challenging, but very interesting. And when I look backwards now, I can see that we've had a great development of our care. This is from a very well-known publication from Christian Kammerlander from 2010, and it's also my opinion. The fracture is only one of the patient's problems, and sometimes not even the worst. Orthopedic surgeons nowadays are not only focused on fracture fixation, but also well aware of the medical problems of their geriatric patients. And that's why, and therefore, cooperation of geriatricians and orthopedic surgeons is increasingly possible and exceedingly important. So, multidisciplinary co-management of hip fracture patients are actually what we call autogeriatrics. It started a long time ago in the UK, and it's now developed in many countries, and clinical guidelines are available, and I think you also have some clinical guidelines in Canada. In Norway, we developed guidelines as a collaboration between the Geriatric Society, the Orthopedic Society, and the Anesthesiology Society. This is a typical hip fracture patient, an old lady which has the signs of aging. She has reduced organ reserves, she has reduced homeostasis, she's frail, she has sarcopenia, she has comorbidity, several chronic diseases, and she's using several drugs. And she's very vulnerable when she falls and break her hips. Excess mortality from hip fractures is very, very much associated with comorbidities, as you see in this graph. So with 3 or more comorbidities, which is very common among older people, the mortality is increasing substantially. So this is our challenge. It is to give better, and I'm talking today about acute care, to older hip fracture patients, to reduce their mortality. And in Norway, our 30 days mortality are between 7 and 8%. And as important, to regain function and quality of life. It's also to prevent new falls and fracture, but that's not topic of my talk today. The levels of organization of care are important to be aware of. Today we are talking about the local hospital level, organization of a unit of orthogeriatric care, what doctors, nurses and others actually do, their routines, their procedures, their skills and knowledge. But we also have to keep in mind the regional level. Not all hospitals should care for older hip fracture patients, and for financial fundings, the regional level is important. And also the national levels, quality control and audit, and of course, national guidelines and political financial priorities. This is one of the slides that is perhaps the most important slide in the FFN. It's created by David Marsh, one of the founders of FFN. And it shows the main principles of care of old hip fracture patients. Keep them alive, to repair the fracture, to increase mobilization, and to prevent readmissions, falls and fracture. And it all should be under the control of quality of care. And we know that orthogeriatric collaboration works. It is shown in many studies that it reduces in-hospital mortality, long-term mortality, length of stay, and it's cost-effective. But the best model of orthogeriatric collaboration is not determined. So what do you need to create an orthogeriatric service? You have the patients, you have the beds, and you have the orthopedic surgeons. And you also have available clinical guidelines. And very important, our textbook, Orthogeriatrics, which has been a project from the FFN and which you can download for free from the internet. It has many chapters that are very practical and where you get very good advices. And can use for increasing knowledge in your hospital. So otherwise you need geriatricians, preferably, but it's also possible to have a good service with other dedicated physicians. Nurses, preferably specialists in geriatrics or orthopedics, physiotherapists, and optional but still important occupational therapists, pharmacists, and social workers. Here are the orthogeriatric care pathways: A, B, C, D, and E. And as you see, most of these pathways are actually at least starting in an orthopedic ward. It's only E that is where the whole pathway is in a geriatric ward, and where the orthopedic surgeon is a consultant and is of course operating the patients. In Norway, we have orthogeriatrics in, at the moment, I think 15 of 50 hospitals. So it's not well distributed and we have a lot of work to do. Most of the hospitals have orthogeriatrics in the orthopedic department, where it's a geriatric consultant team integrated in the ward. 3 hospitals have geriatric departments with orthogeriatrics, and there are 3 hospitals who are now developing orthogeriatric services. We have a National Hip Fracture Registry in Norway, so you can go into it and have a look at the actual figures. So I will talk a little bit about cost effectiveness, because that is extremely important. And it's also important as an argument for our manager and political leaders when we want to develop orthogeriatric care. In Norway, it is a cost of about 450 million euros per year hip fracture care, and one hip fracture patient costs about 50,000 euro. But it's a big difference between the three different groups of patients. Group 1 are those we can discharge at home after hospital stay. Group 2 are those who go to a short stay in a rehab institution for approximately 3 to 4 weeks before they are discharged home. And group 3 are those who are ending up in long-term care. And as you see that those ending up in long-term care are about the double costs of those we can discharge to their homes. So it's extremely important that we are treating the patients so they can avoid going into long-term care. This is from actually from 2 Norwegian RCTs on orthogeriatric care, the Trondheim hip fracture trial and the Oslo hip fracture trial. And both are treating the patients in geriatric department with the orthopedic surgeons as the operator and as a consultant. And as you see, there are not so many significant results here, except that the geriatric care group, they had a longer length of stay. But after this, after 2015, when the studies were finished, length of stay is reduced to 6 to 7 days, also in these units and in all over the country, actually. So the difference here is, even it's not significant in this figure, is that more patients were ending up in long-term nursing home in the orthopedic group. We also have to think about which of the hip fracture patients actually benefit from orthogeriatric care. And it is some variation of the patients. Not all of them are very frail. We have fit older patients who have fallen outdoors, and we have the frailer ones who have fallen indoors in their own homes, and we have those coming from long-term care. And the studies, they are mainly including those who are in the fit group, and those are the frail but home dwelling group. And we know that they have benefits. It's actually in Trondheim hip fracture trial a better benefit for the most fit patients, which was a surprise to us. To sum this up, orthogeriatric care is for the whole pathway of the patient. It starts at the admission with diagnostics, not only of the fracture, but also of comorbid diseases and physiology, optimization and early surgery is a main principle, medical treatment of comorbidities, prevention of complications after structured protocols, falls, delirium, etc., and early mobilization, which should start on the day or the day after the operation, and then further rehabilitation. So we can say that orthogeriatrics is the gold standard, it's better for the patient, and it's cheaper for the society. Thank you for your attention.
Thank you very much, Dr. Ranhoff. That was a really excellent talk. And I can see a lot of the things that you're talking about are being very relevant to both my local area as we're trying to develop these services, and also with a lot of discussions that I've been having with colleagues and others who are interested in orthogeriatric care as well. And I really look forward to our discussion towards the end of the webinar when I'll be joined by the other panelists as well. I've definitely written down some questions to be asking you as well. So moving along, I'd like to introduce our next speaker, who is Amy Hummel. Unfortunately, Amy isn't able to join us live today at the webinar, but she has very kindly recorded her talk for us so that we'll still be able to benefit from her expertise. And her talk is entitled Fundamentals of Care, Best Practice for Hip Fracture Patients, the Swedish Way. So Amy Hummel is a certified nurse specialist in the Department of Health Sciences and the Department of Orthopedics at Skans University Hospital, an associate professor in nursing education, Lund University in Sweden. She is scientifically and clinically active in the nursing aspect of hip fracture patients, involving the whole treatment journey from fast track handling within the ambulance all the way through to reducing wait times for operation, pre and post operative care, and rehabilitation. So I look forward to Amy's talk now.
Good evening. Sorry I can't be with you today, but I have pre-recorded my session and I have photos in my presentation that both staff and the patients have agreed and given me permission to show them. I will start with a short information about my country, Sweden. Sweden is one of the Nordic countries, and even though it's quite a big country, we are only around 10 million inhabitants, and patients with a hip fracture are operated in 51 Swedish hospitals. And I'm working down in the south, both clinical at the hospital, and I am also teaching at Malmö University. This is the Swedish hip fracture population. Every second, a Swedish woman at the age of 50 will sustain a fracture during their remaining life, and the lifetime risk for a hip fracture at age 50 years in Sweden is for women 23% and for men 11%. This is Lund University Hospital, where I did my first research study. The sample I will show you in the presentation derives from a study of 478 patients consecutively included between April 2003 and March 2004. And on October the 1st in 2003, we introduced a new evidence-based clinical pathway. All data at admission were collected by myself and my colleague, and one of us was always available for the A&E through the year when the patients were included in the study. And every day, one of us visited all patients included in the study at a different ward. And we did a risk assessment, and pressure ulcers was performed daily during the first 8 days. On day 5, the nutritional status of each patient was performed, and I also did home visits after 4 and 12 months. And I think that many of you know the short portable mental status questionnaire, also called 5 test. This instrument has a good validity and reliability. And we use that in the study when the patients arrive to the A&E. And this instrument is also included in the National Hip Fracture Database in Sweden. And to prevent confusion and local tissue hypoxia, already in the ambulance, the administration started of oxygen preoperatively and during the first days postoperatively. Oxygen was administered until the patient was able to keep saturation above 90%. And the intervention with the intravenous glucose liquid was to improve the patient's fluid and nutritional balance before surgery and to stop the catabolic process. We were also given all patients adequate pain relief at the A&E with a combination of paracetamol and morphine. And part 4 was the changing of routine so that the patients didn't have to return back to A&E after X-ray. Instead, they were transported directly to the orthopedic ward to decrease the time on hard surface to minimize the number of staff needing and to minimize the number of staff needing to introduce themselves to the patients. And all staff was educated in a pressure ulcer classification according to the European Pressure Ulcer Advisory Panel's classification. And we use the modified Norton scale. This is developed and tested for Swedish settings. And we introduced that to all staff so they were aware of the risk the patient had of pressure ulcer. And we had a lot of education for staff, of course. But also the part 7 was the introduction of a nutritional drink given twice a day postoperatively. And we did, as I already had said, nutritional screening on day 5. In the study, there was no significant difference between the control group and the intervention group according to gender, age, and lucidity. But early surgery within 24 hours was significantly associated with reduced length of stay. And when 4 months had passed after the fracture, the total mortality was 12% in women and 20% in men. And there was a significant difference in 4 months mortality between patients operated with no delay compared to the group with administrative delay. And mortality at 4 months follow-up was significantly higher in patients who had suffered from a hospital-acquired pressure ulcer. And one way of saving has been the reduction of the amount of beds at hospitals. The consequence is that acute patients inappropriately are admitted to non-specialized ward because of a limit of beds. These patients are also known as outliers. And I have to say that the strict amounts of saving costs have resulted not only in economic consequences with prolonged length of stay, but also in patients suffering an inconvenience of postoperative complications because of increasing number of complications. This is my thesis from 2007, but of course we have moved on, and today the 911 call center is involved so when there is a suspected hip fracture, the patients, they are always prioritized. And the ambulance nurses are established the patient's identification. They draw blood samples and they also take the ECG. And the A&E is bypassed, so the patient is transported directly to the X-ray unit and then to the orthopedic ward where we always have a bed, and the patients are also prioritized to get surgery. And as you can see, it only takes 8 minutes at the X-ray unit now, so it goes really fast for the patients to come to the ward. And as you can see today, there is many persons that are lifting the patient instead of, as it was before, 2 X-ray nurses. And the patient is, after X-ray, lifted directly to a bed. We have a bed in Lund at the X-ray unit, so that is very easy. And this is a 86-year-old lady. She fractured in the morning, was operated during the afternoon, and this is the next morning. So time to surgery is a national goal today in Sweden. 80% of patients should be operated on within 24 hours. And all hospitals in Sweden have fast track today, but of course it looks different because of the different organizations. But most hospitals have focused on pain relief. They are administrating different blocks. Also, nutrition is an important issue, and many hospitals have started with pre-operatively oral carbohydrate drinks. And of course, we have focused on prevention of complications such as delirium, pressure ulcers, urine retention, and different infections. And All this goes along with the chapter in the 5th edition of the Evidence-Based Geriatric Nursing Protocols for Best Practice. I, together with other ICON representatives, have written a protocol on acute care management of the older adult with hip fracture, and this protocol includes the background research that supports the recommended interventions. And that is all I have to say today, but I'm sorry I can't be with you and answer questions, but please don't hesitate, just email me, ami.hommel@MAU, Malmö University is that, mau.se. Rona had the email address. Have a nice evening, bye.
So many thanks for Amy again for presenting, and that's very kind of her to also provide her email address. So perhaps we can circulate that after the webinar, or perhaps put it in the chat so that if anybody does have any questions for Amy, they'll be able to email her directly. Or if you have any questions, we'll see if myself or the rest of the panelists are able to help you try and answer them later on today. So our next speaker is Sebastian Lackey, and he will be talking about hip fracture care in Alberta using data to drive quality improvement. So Sebastian is a quality improvement manager at the Alberta Bone and Joint Health Institute, which is an independent not-for-profit institution that is leading bone and joint health knowledge and research in Alberta. So Sebastian completed his PhD in molecular biology and genetics at the University of Alberta before doing postdoctoral work in the field of pharmacology. For the last 7 years, he's worked on managing large-scale scientific and health projects across Canada. So thank you very much, Sebastian, for taking the time today.
Thank you very much, Jenny. I'll just get this started up and we can dive right into it. So thank you very much for the introduction. And I just want to take the time to thank FFN for giving me the opportunity to talk today. So I'm going to be going over some of our hip fracture successes in the province of Alberta in Canada, and outlining the value of data and how we can use data to drive most of our quality improvement efforts in this field. So before I dive in, I'll give some background about the Institute. We're a little bit unique in what we do, but we were founded in 2004, and our main focus, like Jenny said, was focusing on improving the quality of care given to patients in Alberta with bone and joint conditions or trauma injuries. And so if we look at what the Institute does, we've kind of broken it down into 4 main buckets of work that feed into a cycle of quality improvement. So we look at a lot of data collection, measurement, and evaluation through KPI reporting. This leads into sort of knowledge transfer and that exchange of knowledge throughout the health jurisdiction that we've got. We're very focused on the development, establishment of consensus-based evidence care pathways that guide care within the province. And then we have a sort of a project management branch that focuses on a lot of this change management stuff. So our main currency within the Institute is data, and that's what we're best known for, as being sort of the holders of the data. So this all revolves around the collection, the cleaning, and the linkage of healthcare data within our data repository. And then we use that source of data to perform analytics and do a lot of reporting that is then reported back to the clinicians and the administrators and all the stakeholders that we have in the province who have skin in the game. One of the great things about ABJHI is that we are independent from the system insofar as AHS is the main provider of healthcare in a public system in the province. And we do have independence from them, even though we strongly collaborate with them. So we have that sort of third-party objectivity that is very valuable. So I talk a lot about sort of data being our main currency, and there's a lot of data sources that go into our repository, and I'm not going to go into them all in a lot of detail here, but this data repository was actually, the data was beginning to be captured in 2002, so it preceded the establishment of the Institute by a couple of years. But we have this very comprehensive provincial data set that we're using to drive quality improvement across a lot of our projects that we're doing. We also have affiliation agreements, data affiliation agreements with many clinicians and providers, and that also feeds into our system. So it's a very robust data set that we're working with. So for the rest of the talk, I'm just going to talk about our hip fracture care in the province. And I want to sort of talk about, we're all aware of the burden of what's happening, but we know that by 2046, that in Alberta, the number of elderly is expected to double. So by then, we'll be looking at roughly 20% of our population will be in that elderly range. And we know all the sort of the burden that's going to come from that, particularly as it pertains to hip fracture care. And we know that the boomers are working their way through the system, and that the demographics are really going to push and strain the system. So we're looking to find economies wherever we can. So the Fragility and Stability Program is one project that is focused specifically on sort of osteoporosis, bone health, but more importantly, patients that have suffered fragility fractures, namely hip fractures. So the Fragility and Stability Program is actually sponsored by the Bone and Joint Health Strategic Clinical Network. So this is a structure within Alberta that we have, and this is, like it says, the clinical network is focused on bone and joint health, and we've partnered with them to create this Fragility and Stability Program, where we've invested heavily in quality improvement projects that are working to improve care for this group. And our main thing is a focus on care pathways and then KPI reporting to establish successes. So I won't go into too much detail about the structure, but we do have the governance of this program is multi-layered. So we have the SCN, who is of course the main sponsor, and then they have many projects, one of which being the Fragility and Stability Program. And then within that, we have committees that guide the direction of the program and how the sub-projects are actually going to be executed. And then we have provincial working groups that are made up of stakeholders from all the hip fracture sites across the province. And these working groups are very valuable in our dissemination efforts and our feedback mechanism to make sure that we're doing things the right way and that communication is appropriate and that everyone knows what's going on. So the Institute, we have our finger in the pie all the way across this. We help facilitate the program and manage it, and that's sort of our role. So when you look at Alberta, it's a relatively large health jurisdiction. We have 15 hospital sites within the province that perform hip fracture repair surgeries, but there's great variation across these 15 sites. The University of Alberta Hospital in the provincial capital, they deal with roughly 500 hip fracture repairs a year, whereas some of our smaller, more rural sites might only be dealing with half a dozen hip fracture repair sites a year. So we're trying to apply these quality improvement programs across a pretty diverse range of sites and stakeholders. So our major tool to drive awareness and change are some KPI reports that have been established throughout the length of the program. The Fragility and Stability Program itself was established in 2012. And we've been using data to do small sort of sub-projects within this. And I won't get into detail about all the little projects, but collectively, those little projects have led to sort of some fairly significant improvements that we've seen across the board. And we're using our KPIs to sort of monitor this. And then when we see issues in the KPIs, that is a point of address that we can then come up with a tailored solution for, which would be a new project. So if we look at the KPIs for hip fracture, we're tracking surgeries performed within 36 and 24 hours from first presentation to the OR. We're looking at mobilization post-op day 1, We're obviously tracking length of stay, return to previous living environment, and where the patients are reaching their final destination within 28 days. We also look at readmission up to 30 days post-discharge, hospitalizations, refractures within 1 year, and then of course we're looking at mortality of these patients following up to 1 year post-fracture. So I'm going to talk a little bit now about some of our successes, things that have improved greatly. So if we look at the surgical volumes since 2003, this is sort of just an indicator of what we're dealing with, this increasing burden within not only a growing population, but an aging population. So our volumes, our surgical volumes in almost 20 years have gone up just over 50%. When we look at the number of patients reaching the OR within these set thresholds of under 24, under 36, or under 48 hours, we've seen improvement across the board. So this is very promising. We still obviously have work to do here, but having this data is going to help us push this change throughout the province. When we look at time to OR, just on average, since 2012 and the program's inception, we've reduced it by just over 7 hours, and roughly we're going along at about 50-minute reduction per year, which again, these aren't sort of huge leaps and bounds, but collectively over time, it does reflect a very strong improvement in patient care and their outcomes. One thing that we look at, of course, is blood transfusion rates. So prior to the start of the program, they were fairly consistent, up around 38%. And we've seen, again, since inception, a pretty dramatic dropping off all the way down, 17% down. So if you were comparing this based on volumes last year, that's just over 500 fewer transfusions per year, which of course is great for the patients and great for the system and the payer. When we look at length of stay, this one, of course, is very important from a resource allocation standpoint. We're trying to get length of stay down as much as appropriately possible. And our successes here have been a bit more modest. We're seeing slight reductions over time. And again, this is going to be a focus going forward of how can we get these patients discharged appropriately and get them home. Obviously, some of the figures we've seen from the Scandinavian countries today, we've got a little bit of work to do here, but we're enthused to pursue that. And then the sort of the one thing that the surrogate measure for success and the number one thing we're focusing on, of course, is our mortality figures. So if you look at the average before the program's inception, our inpatient mortality was at 4.7%. And since the program's inception, we've had just a pretty clear step down. It wasn't the sort of the gradual change that we saw in the blood transfusions. All the attention and focus that was sort of a result of this program's start, we've seen this drop down to 3.5%. And again, it's hard to pinpoint cause, and you're making inferences, but all these little collective QI programs have contributed to this. And again, when you're trying to make comparisons based on volumes that we're dealing with now, this reduction would translate to roughly 38 lives saved per year just on the inpatient front. And then if we look at it from the episode mortality standpoint, it's a very similar trend. And we've gone from 6.7 down to 5.1, and this would again translate to about 50 lives per year based on our current volumes. So it's a lot of work and resourcing has gone into this, but the point I want to get across is that data really takes a lot of the ambiguity out of it. And once you start to quantify these things, you can really push for change and measure change. And even if that change is incremental, it's great to see it happening. So I want to take a brief period here just to say thank you, not only to the partners that we have at the Institute, but to all the providers and administrators and all the stakeholders in the province of Alberta who have bought into this program. The structure of the program that we have is entirely dependent on our working group members and our committee members and the time and effort that they put into driving this change. So I think they deserve a lot of credit for some of the successes I've shown you guys today. So that wraps it up for me, and I'll hand it over to Jenny and the panel again. Thank you.
Thank you very much, Sebastian. And it's great to see all that data there to really see in hard numbers what we're hoping to achieve in many of our programs here. So I would encourage all of the participants who are here today, if they have any questions, please put them into the chat. We are keeping an eye on it and moderating that as well. And whilst you are coming up with your questions, I would like to introduce our two other panelists today who will be joining me. So we have Dr. Pierre Guy. Dr. Guy is a professor and clinician scientist at UBC, the Department of Orthopedics, Division of Orthopedic Trauma, and he's the co-director of UBC's Center for Hip Health and Mobility. And his research is focused on hip fracture prevention, treatment, and post-injury function, as well as pelvis and acetabular fractures. So thank you, Dr. Guy, for joining us today. And I would also like to introduce Patricia Dixon. Patricia is the Advanced Practice Occupational Therapist at Sunnybrook's Holland Bone and Joint Program. Patricia has over 20 years of clinical experience and a special interest in hip fractures. She's also a lecturer at the University of Toronto as the chair of the Ontario Rehab Care Alliance Hip Fracture Task Group. So welcome, Patricia, also for joining us today. And I believe that Lauren will be helping us to moderate the chat. So whilst we're waiting for any questions to come in, I just wanted to open up to Dr. Pierre and Patricia to see if there are any questions that you have for any of our speakers today, either Dr. Ranhoff or Sebastian here who's joining us.
Yeah, I mean, I had some questions myself for Dr. Ranhoff, that just to get a sense of you know, you mentioned that the program, you know, there's some geriatricians available in Norway, but not everywhere, and that's very similar to what happens in Canada. I'm just trying to get a sense of who provides the care in other hospitals. Is there some type of other model that you would suggest, or something else that's happening in your country? Because that might be very helpful for some people from Canada who are on the line now. So if it's not geriatricians, are there other people who are providing the care, and who are, what field of medicine would they be from?
Thank you for that question. This is a very relevant problem also in Norway, as you heard, because there are only about 15 of the 50 hospitals who have orthogeriatric service with the geriatrician set up. So in the other hospitals, some places they don't have a sort of regular service of physicians, of internists or similar. The orthopedic surgeon has the main responsibility for the patients. And if a patient, say, get the chest pain, they are calling the internist or the cardiologist to come and look at the patient. But they don't have a sort of continuous and regular service. In some few places, they have a physician connected to the unit, which is not a geriatrician, but a specialist in internal medicine, most places. And those specialists, they are quite skilled to do to go into the team. But the studies that have been made, the RCTs on orthogeriatrics, they have all included the specialist in geriatric medicine. So we don't really know the quality of the units where they have an internal medicine specialist as a sort of coming in instead of the geriatrician.
Yeah, but I'll share with you I think that there's huge benefits in that, understanding the population, not just, flying in to help with a little problem, but actually being part of a whole team. That's what you're promoting?
Yes, I think it's important to have a doctor that is looking after the rest of the patients, not only the hip, but the rest of the bodies, and that it is some continuation in the care, because that gives a much better care. That's my my experience actually. I can remember from the early days around 2000 where I was on call as an internal medicine doctor, and I got these calls from the orthopedic units to come to see the patients, and quite often I was coming late in their sort of progress of their problems, their complications of the after their hip fractures. So and I think also that I mean, we have the clinical guidelines, and if we are using them, most places they are quite detailed on what to do with all these complications and problems, and structured protocols for prevention of complications. So if you are using those, and if you also have a team with the skilled nurses, a physiotherapist, and a doctor who is, to say, good in internal medicine, then the service can be quite good.
So thank you for pointing that out, that it's not just about the geriatrician, but it's about the whole system and having a whole team.
The whole system, and I think the team is the important thing.
Yeah. May I with this? Want to follow up or?
Yeah, go ahead, Dr. Gee.
So you had mentioned that there might be some patients who benefit more from the orthogeriatric service than others. Is there a sense of that? Is there sort of some way to guide that? So if I'm just thinking of the situation where people might be limited with their resources or access. Is there a population that you would say would be more would have the biggest benefit from that service? Or?
The Trondheim hip fracture trial actually showed that the most fit patients had the best benefit in where you achieved a better function than the patients who were treated in the orthopedic unit, and the difference was bigger for the most fit patients, which was a surprise to us. But I think that the reason is probably that many of the very frail patients, they are in a way in a point of no return on their decline in function. So you don't have the same effect on your intervention. And that is particularly true, I think, for many of the long-term care patients.
And Dr. Ranhoff, can I ask, when you're talking about fit patients or the not so fit patients, was there a way to kind of quantify that? Is it through a frailty score, or is it through comorbidity or anything like that? Is there any data we could use to try and determine?
We don't have that data in the Trondheim hip fracture trial. I think there are some data on pre-fracture mobility. So those with the best pre-fracture mobility, they actually gained the most because they lost less when they got geriatric care compared to orthopedic care. But I did an analysis of our patients in Diakonhjem Hospital, because we have a big quality database with many thousand cases, and we looked at a very simple thing: falling outdoors or falling indoors. And we found that the patients who were falling outdoors, they were much fitter in all sorts of ways. In their ADL, in their comorbidity, they had much less comorbidity, and they were also younger than those who had fallen indoors. So that's a very easy way to actually categorize the patients if they had fallen outdoors or indoors. So that was what I showed in my slide.
Okay, thank you very much. And we just have a comment here from Ann Nelson saying that a frailty scale would be good to be used as, for example, the one developed by Dr. Rockwood. Trish, you look like you have a question to ask.
Oh, I had a question actually somewhat related for Sebastian, sort of tying the two together. Knowing that Dr. Ranhoff was saying some hospitals have geriatrician management, some don't. Some are able to really well follow the clinical practice guidelines and the pathways, and some aren't. And your system will pick up that in data, which is fabulous. How does the system manage outliers? Do you have a team that speaks with the hospital? How do you do that?
So there's, again, like I said, we're a pretty diverse jurisdiction. There's the high volume hospitals, the low volume hospitals, and there's different models within each hospital. We don't mandate one model of care over another. We provide the care pathways, and they sort of are the foundation. That's sort of the base requirement there. And then when we look at the data, it's kind of a collective measure of everything that's going on in the province. And when we look at our KPI reports, you can look site by site and you can pick out the variations. And we actually have a feedback mechanism where we say, okay, this site is struggling on this specific KPI, or what's more important is we're not Big Brother looking over your shoulder saying you need to get your KPI up to here. It's more so you look historically at a site and you say, okay, you've been around here, and then something dramatic changes, whether it was for the worse or for the better. And then we go back and we say, okay, what caused this? What was, and then, I mean, COVID has thrown so many spanners in the works. It's been crazy. And so from the outliers, when we look at the site to site, we're not really sort of trying to get everyone in step in terms of outliers. And then in terms of the data cleaning and stuff like that, it's a very delicate process that people far smarter than I deal with. But it's certainly something that we have in the data that's coming into our repository.
You know, and I would add to that, Sebastian, we look at those outliers in the KPI reports, we very much look at the volumes of the centers as well, right? Because if you have one patient in a very small rural center who goes off the pathway, you know, it changes their parameters substantially. So we're very much aware, you know, about looking at, as Sebastian said, what it is. The committee, the group is very engaged in Alberta, and very, you know, it is not a pointing fingers, you're doing badly. It really is sort of looking at, well, how are you doing that so well in some sites, and can we do that? You know, and, you know, what is happening and what could we help you to make it better? And so the groups do see the KPIs as really a useful tool to be able to communicate with sites that are similar to theirs to say, well, how are you doing so much better? What are you doing that's different than what we're doing? And so it's been a very effective communication tool and, you know, collaboration tool.
And I will say, I'll just add on to that. I don't want it to come across as if sort of we are the ones, or the SCN are the ones drive. Sometimes a site will do something of its own accord and we'll see a positive and we'll say, wait a minute, what happened there? And then it filters back to the working group. So you're having this sort of autonomous QI thing that's filtering throughout the whole province, and that's really powerful. And that communication thing is one of the great benefits of all of this.
And Sebastian, can I ask you, like, I would love to be able to get this sort of data for our hip fracture unit, but we don't really have the sort of resources that you guys have. Do you have any suggestions on like how to get administrative buy-in, or do you have any tips on how to start developing a quality improvement program to develop this data?
Yeah, so I mean, that's the big question, right? Is this all sounds well and good, but none of this was free. This took a lot of investment from the Alberta government. And so I think ultimately you kind of have to have a champion. Someone really has to be the one who's going to go into bat for this. And I would recommend that whoever that champion is they look at successful jurisdictions and they take those examples to the administrators or the decision makers, whoever the payer is. And you really have to say, I mean, for hip fracture care, it's really interesting because healthcare administrators, for better or worse, are often sort of focusing on the now and sort of what the costs are now. But I mean, you can really get some eyes to open up when you say, look at these population demographics, look at this burden of disease for osteoporosis and aging. And they really, you have to hammer home that they're going to have some foresight on this, or you're going to get swamped later on. And then I recommend not only having the champion, but you really do need to invest in experts on the analytics side, and that can be difficult. So whether it's repurposing resources that already exist, but clinicians are so busy these days, they're excellent champions for things like this, but you really do need an investment on this data collection side and the analytics side to really drive it. As to sort of twisting arms and getting it done, I mean, I think that's going to be up to you and your champion to really push this and get through to the decision
But
making.
I agree, Sebastian. When we developed those ones in Alberta, one of the things that we did is we had more KPIs than that. And what we really came down to is we really looked for ones that were in currently collected administrative data. So ones that did not require manual data collection. The only one that we have right now, Sebastian, I think that is manual data collection is the early mobilization. And we actually did test it as a CIHI field. And we actually have a definition that could be used at CIHI and embedded into that with some, and be actually sort of useful, I think, beyond hip fracture care. In fact, our orthopedist said, just put the date. Don't say day one mobilization, just put the date, because then we can use it in arthroplasty as well, because we'll just record the date they had the surgery and the date that we mobilized them. So really administrative data pieces, because then you take that work. As soon as you make it manual data collection at the clinician's bedside, it drops off. Whereas these were really, most of these are CIHI indicators, right? They're available pieces. So then you're just repurposing what's already being collected and setting it up as a local report. And Annette, I would wonder the same thing for you in Norway. When you look at your registry, how many of these are sort of manual collections and how much of this is sort of automated to try and reduce, how much work it is for clinicians to track this, and how you might have approached that as well?
I can tell you a little bit about that. We have the national registry, which is now quite automatic, and it's the surgeons who are actually collecting the data, and there are basic information about the fracture, the type of surgery, also waiting time, and some very few complications. And I also have to actually tick on if the patient has some cognitive impairment or not. And we have recently evaluated that by comparing the orthopedic surgeons assessment and with the 2 units where we had the geriatricians. And it was really quite good. So I think the eyeballing of cognitive impairment from the orthopedic surgeons is valid. In my hospital, we started up already in 2007 with the hospital quality database, which has been very, very useful. And we have more data than in the national. We also have a registration of pre-fracture ADL using the Bartle index. We have something about the mechanism of the falls, and we have, which is probably the most important, complications, both delirium, falls in hospital, infections, pressure ulcers, that's the most important things. And that the database has been really very useful for us, because we are making every half a year a report where we can see what is good now and what is less good. So if, say, waiting time for surgery is increasing, we make a point of that. If we have more chest infections, we make a point of that. If we are low on delirium, we know that the registration and the detection of delirium is not good enough. So we are using that in the department. But I must also say that it requires some champions, some enthusiastic people to actually not only use the database, but to secure the data collection, and that is a challenge actually. So we have one nurse, Mette Martinsen. She has been very active in the FFN. She has been in charge of this for many years, but she has never sort of got extra time for doing it. So I think it's extremely important that you actually have financing and you have people that are dedicated to do this. But it's very, very useful. And we also, when we started up, we had discussion with the ethical committee and the data inspector, but we were allowed to include patients without asking for consent, and that make it possible to include 100% of our patients, which is really a very important thing when we should use it as for quality improvement.
Dr. Ranhoff, can I ask you a somewhat related question? That it sounds like at your hospital, you have all of these databases in place and a lot of experience. And you mentioned that there's 3 other hospitals that are currently developing their services as well. Do you have, are the different centers in Norway collaborating at all in any way to kind of share best practice with the hospitals that are developing their services at the moment? And how do you do that if you are?
We have a group in the geriatric society, a special interest group on orthogeriatrics. So we meet there, and the geriatricians who are working with the hip fracture patients, we all know each other very well. So we have meetings usually 1 or twice per year, but we also have a lot of mail exchange, and we are helping each other. So that has actually meant a lot. And we also have 2 centers where they have done a really good scientific development, the Trondheim and the Oslo University Hospital. So they have done these RCTs, and they have also been very willing to share their experience and knowledge with all the others. And then we also have the FFN, and now these geriatricians are also involved in the FFN, where we have annual meetings though, and a network, so we can communicate.
Fantastic, thank you. And Laura Gregoria has just put a comment in the chat box, and her question is, are there standard practices or programs for implementing home exercise in people with hip fractures, or guiding principles, for example, inclusion of balance exercises, lower body functional strengthening, etc., or pathways for connecting people to community programs?
So Annette, I was going to say, Annette, please answer first.
Yeah, no, I don't think we are very good in that. We have some guidelines from the physiotherapists, but they are mainly focused on the hospital stay and then the early rehab phase. But when that's said, we've had some studies that have been quite well known in resistant training for hip fracture patients, but that has been after 3 months. After 3 months after the fracture. Okay. But we don't have a good standardized protocol for home rehab of hip fracture patients. And I think that would have been very useful.
And I see, Laura, that Pierre shared some things that we had, and I'd invite you, Laura, to go back to the Bone and Joint Canada site or the FFN site, because we held a rehabilitation webinar last week. And in fact, we covered a lot of these things. And Spain has a really interesting program that is about a transition out into the community and home health, particularly for places where people are living in rural environments. Like right now it's in Dutch, Portuguese, and Spanish and Catalan, but we are looking at, can we get it translated into an English program as well. So there was a good conversation last week about both data in the acute care as well as these transitional pieces. So please visit the Bone and Joint Canada or the FFN website to see some of those as well. Pierre, maybe you want to elaborate on what you have as well.
Oh yeah, I shared the link actually about the Fresh Start toolkit. This is a project that started with Maureen Ash, who's a physiotherapist and a clinician scientist here at the center at UBC, and where we included some of her work into our provincial initiative, the BC Hip Fracture Redesign, and translated this toolkit in 6 languages. So it's actually available for download. I mean, it's more adapted to BC, but certainly the content in it is there. And the idea is to guide patients through their journey beyond, beyond just the hospital stay. So,
Pierre, I was going to say, I give this out all the time. because I'm in the unique zone where I see patients for their hip fracture follow-up in the fracture clinic. And I give out the booklet and make sure they know all their exercises. And then I typically tend to, because I cross over from elective arthroplasty to hip fracture, I also tend to include some basic post-total hip arthroplasty, core strengthening, abductor strengthening exercises along with it. And it's really successful. Patients love this toolkit. They love the fact that there's a little pathway they can actually physically see. It's beautiful. So good work.
Well, yeah, I credit the Maureen on that. It was actually designed talking to patients who've gone through a hip fracture event, and from there the booklet was born. So where, what did you wish you had type of thing.
And Joe, just to add to this, and talking again, Pierre, about international collaborations, Patro, who's presented last week with the Spanish program that they're doing, the origin of that program was from UBC with Maureen and Fresh Start, because Patro had come over from Spain and done a visiting scholarship, and she took it back and she's advanced it. So it's quite a bit bigger than what the Fresh Start was. But the base of the program in Spain is in fact the Fresh Start in UBC. And so again, the connections for Maureen and Patro were through the Fragility Fracture Network. And this is exactly what I'm talking about, these international collaborations where you really build on successes in other areas of the world. It's surprising how common our global problems are. And so hopefully our solutions can be somewhat global at the big and then bring it down to local practicality and application. So yeah, great program here, but it's found a whole other places in the world.
Yeah, that's interesting. It was great to hear that. I had a question, if I may, Jenny. Yeah, for Sebastian.
Yes.
So we've been involved, in BC as well with larger scale, but we haven't been as successful as you have, and I don't think we've had the kind of political uptake. And I would say that in Canada, the gold standard for quality improvement care is in Alberta. Absolutely, the processes you've developed, the KPI, the comprehensiveness of it, and the commitment is absolutely to be recognized and commended. And the improvements that you've shown were just really great. I think to see some of the improvements, for example, transfusion and all that. Two questions that you noticed. You mentioned your improvement in mortality, and Lauren mentioned that this was all discharge accurate database, a CAHI database focused. Do you have information out a year? Because when we looked at our information out a year, we weren't having much of an impact on this population, but certainly I'd be interested in knowing that. That's my first. I'll have another question after.
Yeah, we haven't looked at it recently, and it's not one of our sort of regularly tracked KPIs, but I mean, you've now just sparked interest in me, and that's something we can take back to the committee, and they'll be like, okay, let's have a look at this, and then we see how that translates. Because yes, it's very interesting the temporal effect that some of these QI programs have on lagging things or bringing things forward.
Yeah. The other piece where that was interesting was actually the population cost part that Annette brought forward earlier, and that implementing a system like that actually can divert people away from long-term care. So that's important to, that's something to be recognized as well. That's certainly a reality just from a capacity, but also from a cost point of view.
Yeah, and I mean, getting back to Jenny's question about sort of how do you convince payers or decision makers to pick these things up? I mean, hip fractures are not cheap, and I mean, if you start prevention obviously is a whole nother kettle of fish. You talk about fracture liaison services and all those things, and secondary prevention of fractures. But when you talk about the sort of the broad quality improvement, I mean, if you can start reducing length of stay, if you can start reducing secondary fractures, you begin to get that cost recovery that really it adds up quickly. I mean, anecdotally, I think hip fractures, we were looking at numbers of $68,000 Canadian per hip fracture, and that's just the acute costs coming in. So you've got the long-term costs adding on top of that.
Speaking of cost, while we're on that, is there what would for the number of fractures that you do when you take care of in Alberta per year, what would be the cost of this program? And I don't mean to scare anybody about that, but essentially this, if you wanted to get the best of the best.
It's difficult because we a lot of the infrastructure that we have sort of already exists if this program wasn't even in place. So it's hard to you take 20% of this analyst would go to this program.
Correct. Yeah.
But so Lauren's looked at some things from a cost effectiveness standpoint and your ROI, and I think she can maybe speak to some of that with a bit more clarity than I.
Most of our cost effectiveness has been more in the secondary fracture prevention, the fracture liaison services, which we've been able to show both our low intensity one that goes for the non-hip fractures, if you will, and then the high intensity one, which looks at post-hip fracture care. Both are cost-effective programs, right? And actually pretty close to cost savings with some revisions, which we were doing. We actually, I don't know that we've looked specifically with some of these data, especially. It's probably another thing that we could do is another formal cost effectiveness analysis on sort of the acute care pathway and that managed care, because I don't think we've actually done that. We focused more on this secondary piece of preventing the next fracture, right? And trying to encourage people that that was the other piece that links into this. As you saw, Sebastian, we laid that out to the areas where the fracture liaison service and then this acute care piece, and they're linked such that, you know, people with hip fracture are absolutely engaged into a fracture liaison service. And, you know, you sort of think, well, maybe that's too little too late to catch people at their hip fracture and think about bone health prevention at that point. But it's actually, you know, highly effective. We've had huge increases in the number of people who start appropriate medication and just appropriate care after fracture, and it's cost effective, even in that group where you're looking at them quite a bit older. Our low intensity program, though, was also cost effective, but we actually haven't looked at, and we can't really separate these things out because they're happening concurrently, but Sebastian, we haven't sort of factored in what the, you know, cost effectiveness of early to surgery and sort of this more controlled pathway approach has been. So yeah, that's an interesting question.
Yeah, and I mean, when we, sorry, Annette, I was just going to say quickly, when we look at time to OR, I don't want to say the majority, but a lot of our focus has been on time to OR. I mean, it's just in terms of a surrogate measure for things that are going to have positive outcomes, not only for the patient, but for the system. The patients are so much better off when they get in early and then they're getting discharged to home and they're not going to long-term care.
Taking that delayed time to surgery as part of that length of stay, right? So the faster you get them to surgery, the faster they can start the recovery. Annette, you had something to say.
Thank you very much. We have a discussion in Scandinavia at the moment. Because we have a quite short length of stay in the hospital now. It's an average of 6 to 7 days, and some places they have shorter. In Denmark, they have very, very short time in many hospitals, and it's a discussion if the time in hospital can be too short, because some of the patients, they get complications after the 3rd or 4th day that are very important to pick up and to treat in a good way. And it's also something with the early mobilization in a situation where the patient still have pain and is still not in a very good condition after surgery, etc. So in my opinion, the length of stay in the hospital can be too short, and that can give a poorer result in the long term. So, and of course it depends on where are you sending the patients after hospital. If you have a really very good rehabilitation unit with good medical services, it's perhaps okay. But if the rehab facilities are not very good and with the low sort of knowledge and no specialized nurses, etc., I think the results can be much more poor if you have a short length of stay in the hospital.
Thanks, Annette. I think that leads into, well, Patricia, and you probably can talk to this because you see patients come back at their 6-week visit. And, you know, what are the gaps that you see in the care that was provided, you know, where patients come to you and it's like, oh, we didn't talk about all these other things that might be important to you, you know, sort of mobility, nutrition, all those other things that happen. So maybe you want to speak to sort of what Annette's talking about, you know, if you try to rush the acute care too much.
Yeah, I think Annette has a really good point too. It really does depend on what the next step is after acute care. I know that there are some patients, sort of regardless of how well or not well they were before surgery, if they go to a couple of very specific places, they are very slow when they come back. So it's not about the patient, it's about where they went and how that center follows best practice guidelines. And we try to work with them as best we can because they're our partners. But this is where data sets like Alberta might help to sort of smooth things along to help everyone follow best practice guidelines, getting people up. I have to say, being the chair of the Rehab Alliance hip fracture committee, my dad had a hip fracture 4 weeks ago. Anyway, now he's on a bone health medication. That's great. But he's, a big burly guy, so you just don't. Anyway, you don't expect these things. And he didn't get up for 3 days. And and he was at a far outlying hospital, not in the city. And it was me calling the floor saying, did he get up yet? Did he get up yet? Dad, you have to ask to get up, get up, get up, right? And then how many patients does that mean aren't getting up until 3 days after their surgery, right? They got him to his OR within 12 hours. That's fantastic. But getting up is a huge piece. We just finished a big research study here at Sunnybrook where patients are wearing wearable devices. We know the best practice guidelines. We have the care pathways, and still we found if you looked at the information from the wearables, they were getting up, but they weren't getting up as much as they should, right? We're mobilizing, but we need to talk about what does that mean? Does that mean once? Does that mean 3 times? What does that mean in terms of number of minutes they're up, those kinds of things. And then I think, some centers are better resourced than others in terms of change management. So if you take all the data centrally and you're able to say, you know what, this center who's really well resourced can help this other center, or you follow, was it Dr. Ranhoff, was it you that said there was a regional approach in your country? Yeah, okay.
Yes.
And that can help.
Yes. Mm.
Yeah, I think, and Maureen, that's leading to your point about mobilization, Patricia, is it's not just, we get really focused on the first mobilization. We got them up day 1, then you've got to, and continue the mobilization. Got them up day 1 and day 2 and day 3, not
and day 5.
The marker, and then we put them back to bed for 4 days because we don't have rehab resources, right?
So this is what the wearable data finds. We do pretty well actually, day 1, day 2, and then we finish the rehab application and they sit for day 3, day 4, right?
Yeah.
So that was fascinating, and that actually changed practice right away on the floor because the staff had the data right away to say, oh wait, what are we doing? That's the really nice thing about having information sort of fed directly to the clinicians. They can actually make practice changes really quickly, and we supported that. So hopefully it keeps going well. But how do we branch that out across the province? That's kind of what I like about the Alberta system, that feeds data all around. And you can compare yourself, if you're a small hospital, you can compare yourself to another small hospital, as Sebastian was saying. I think it's good to have all of these systems available so that we can succeed. I saw Jenny wanted to say something earlier.
Oh, I can't remember what it is anymore. But there is, I think we're like 3 questions back now. So, but there is a message in the chat for Trish. Rona's just answered it, talking about which data was it that Trisha was talking about. And it's data collected at Sunnybrook on wearables in post-op.
Is this Lynn Haslam's data? Is this from, because I think I saw that Sunnybrook data as well, but yeah, hopefully it'll be published soon. And
I have it. I'll try to put the link in the chat. And it's so one of my nurse practitioner colleagues, Lynn Haslam Larmer, she actually was finishing her PhD research, so she's just worked on that. I think she probably reached out to you, Lauren, at some point.
I was one of her final PhD examiners. Yes, I know that work.
Yeah.
And it was really interesting, I think, and Lynn as well, and I wanted to ask you this about this, is that Lynn took a mixed methods approach. So she had the wearables in terms of what they were actually doing, but she did a lot of talking to patients and caregivers, which is really interesting perspectives about what are the actual barriers to implementation, because it's not always about resources. It's also about beliefs in terms of what should we be doing, and patients thinking, are you sure I should be doing this? This seems crazy to me, right? So I think there's a lot of pieces that we need to work and engage with our patients as well. Annette, when you did your work in Norway, do you do patient engagement as well, where you've got patients as part of the, you know, the group that's feeding into what the needs are, for example, and how you develop what's happening with them?
Oh, we have in our hospital, we have a PPI group, actually, where patient and public involvement group, and we are using them as advisors. When we are actually setting up the goals and the principles for our unit, we have used this group to give advices. And I know that it's very strict now in Norway to have sort of user representatives in research. So in the Trondheim hip fracture trial, they also had some user representatives. I know that. You hardly get any financing of your research if you don't have it.
Right. And I think the other part with this group is that is expanding it out to the caregivers and family members as well, because this is a group that also then allows us to, you know, include perspectives, at least, of the people who are living with people with dementia, if you can't get their input directly, because that's certainly not a group that we can ignore in the patients with hip fractures, when it's, you know, 30 to 40% that we know are going to come in with some sort of cognitive issues, whether it's delirium or underlying dementia. And I think those perspectives are very interesting, because I'm sure, Patricia, it was a very different perspective now to be on the other side of the fence versus being the caregiver saying, or the, you know, healthcare professional saying, this is what should happen, and then this is what's happening to my dad.
You know, it's funny, because I work so closely with patients right after their fracture, I know what happens, but yeah, it's different to be on the other side. And it's different to be, I'm going to be frank, I can bully my own orthopedic surgeons that I work with. I know them, right? And I don't have to bully them. I know what they do in terms of fixation and weight-bearing status and things like that. But I found myself calling up an orthopedic surgeon from another hospital and saying, did you really need to make him touch weight-bearing? Because that's not best practice. And can you tell me a little bit more about that? And let's talk through why you need to. The weight bearing is tolerated and not restricting our patients. It's huge for reducing the fear of getting up and getting moving, right? Patients that I see at 6 weeks, if they go to an outlying hospital or they have contact with any professional who tells them, oh no, you need to be careful about bending over or twisting or, you know, old hip precautions, then they just don't move, right? So we have to be really careful about restricting our patients.
Agree.
Jenny looks like she wants to say something about this one.
Sorry, everybody. This is really fantastic discussion, but I'm very cognizant. We're just 3 minutes over time now. I'm sure we could keep going for the next half an hour. But I would like to thank everybody for joining us today, both the panelists and the participants, and for joining us for the FFN webinar today. Lauren, are we allowed to stay on a little bit longer if anybody had any more questions?
Yeah, we can. What I will just tell people is that this has been recorded, and it will be posted within a few days on both the FFN website as well as the Bone and Joint Canada website. And for those of you who might have missed the rehab one, those recordings are also available to you. Patricia, I'm just making her retype it out because she sent it to the panelists, which is great, thank you. But I'll get her to send it out to all the attendees as well for her piece. But yes, if we'll maybe open up for a last one. Otherwise, I agree, we'll just say thank you. What great talks and great sort of insights from both within Canada and from Scandinavia, which has always been a leader in kind of these national approaches and, pathways and audit. So thank you very much. Rona, do you have anything that you want to add before? And thanks, Jenny, for excellent moderation, and our panelists here, and Patricia for adding your insight.
Thank you, Jenny, and thank you to all of our panelists from Bone and Joint Canada. And then we're really happy with this ongoing relationship with FFN, and so we're going to be reaching out to people on an international basis going forward.
Thank you all. It has been a great experience for me, and I'm looking forward to see you all in the end of September in Toronto. Hope to see you physically within a year or so, though, or a couple of years.
Yeah, no, well, at least we'll be in the same time zone, sort of. Everything will be recorded as well for the virtual Congress, so you will be able to go back and revisit some of the excellent talks as well. So, but it's been great in a webinar to show sort of that global interaction and impact that already we can see.
Thanks, everybody.
Everybody.
Thanks, everyone.
Thank
Okay.
you.
Bye-bye.